Hey, good morning, everyone. We got people jumping in here. Typically like to get these things started a couple minutes before 10, but we made it. We'll give stragglers until maybe 10:05, and then we'll get rolling. But we appreciate you guys tuning in today. We've got kind of a cool little transition going right now between slide 1 and slide 2, but that's all right. Thanks for joining us. We'll get started here soon.
Good morning, everyone, and welcome. My name is TC. Just wanted to say thank you for your patience and welcome to our webinar. We are going to give it a couple of more minutes just to get, make sure everyone gets online. So go ahead and grab yourself another cup of coffee, refill your water, and we will be getting started here shortly. Good morning to all of the new people who have joined us on the line. We will be
Good morning, everyone. We'll give everyone just a few more minutes here. Try and get started at 10:05. That's my cue that it's being recorded, so no inappropriate jokes. Okay. Thank you, TC. Appreciate everyone tuning in, and we'll get started here very soon.
Okay, it is 10:05 on the dot, so we can go ahead and kick this thing on off. Good morning, everybody. Thank you for joining us. My name is TC, and welcome to our webinar this morning. I'd just like to go over a few housekeeping items before I kick it over to Grant and Sean. Once again, welcome. Thank you for joining us this morning. Just wanted to let you know that this meeting is being recorded. So a copy of the recording along with the slides will be sent to you within the next 24 to 48 hours. So be on the lookout for that. Also want to let you know that you can ask questions in the Q&A chat box. So please use that. Grant and I will be monitoring the chat box during Sean's presentation for any questions. And also, you can email me anytime with any questions. Like I said, the recording and the slides will be sent following the presentation. So that was all for my housekeeping items. I will pass it over to you, Grant.
Awesome. Thank you, TC. Those of you who have attended a few of these webinars, maybe you attended all of them, you guys know TC is the brains of the operation. She helps facilitate all this. So thanks as always, TC. We're excited that everyone is joining us this morning. We've got, I think, maybe one of our bigger groups, group of attendees, which is awesome. I know I speak for our team here at InterWest and Pareto when I say, again, thanks for joining us this morning. As the health insurance market continues to harden, new options continue to emerge each and every day, just like new forms of, maybe energy or currency. They're becoming new ways to purchase your health insurance year over year. Health insurance captives are helping our clients not only isolate claims, but implement wellness and take back control of their health insurance budget. Medical trends continue to increase year over year. What medical trend means is that a claim that cost $100 last year will cost, say, $110 the year after, just really for no reason, just kind of how it goes. Sean and his team at Pareto are great partners of ours. We've been working with them for, coming on 8 years now. They've helped us kind of traverse this captive market and the world of stop loss and reinsurance, and helping our clients find the best options for not only the company's bottom line, but also for their employees as well. So we want today to be as interactive as possible. Like TC said, there is a chat feature, kind of Q&A if you want. So we'll be manning that during the session. We are going to try and leave 15 to 20 minutes at the end to answer any questions that might come up. Feel free to email us directly too if you feel more comfortable using an email to ask a question. Would love to hear from some attendees really while Sean's going, and then we could kind of address it at the end. How big's your company? Are you currently fully insured, self-insured, or maybe level funded? And then we could kind of just get a gauge for the audience. That would be super helpful. But, we've had employers from as low as 30 to 40 employees tune into these calls, and some as large as 3,000, right? So looking at the names of the attendee list right now, everyone is kind of right there in between. So again, glad you guys can make it. So with that, I'm going to pass it over to Sean. And again, we'll try and leave some time for Q&A at the end. But Sean, take it away, buddy.
Cool. Thank you, Grant and TC. Appreciate everyone for joining the call today. I am Sean Sanford. I'm the Vice President here in California for Pareto Health. Really, it's my role to be our lead consultant relationship and also for all prospective member education. So all the employer groups, whether they're fully insured, level funded, they use an HRA, they're self-insured, they're in another captive. It's really the primary part of my role is to educate these employers on the opportunity that's in front of them to potentially join Pareto and the value of self-insurance and how you're going to do it, whether it's on your own or with the reduction in volatility through the captive program. So glad to be here. Been a partner with InterWest for a long time. InterWest has done a great job not only supporting and helping grow the captive with their current clients and employers around California, but also the job that they're doing in the trenches once the groups do join the program. Simply put, self-funding is access to control, flexibility, and information. InterWest does a great job of really digging in and managing the healthcare plan versus just managing costs on a 12-month increment. And we couldn't be happier with our collective performance together and the results that they've been able to share with their clients, their bottom line, and their employee experience. So quick agenda for today. I'm going to give you a quick introduction to Pareto Health. I will, throughout the session, I'll try my best to keep it non-biased, right? Captive related. The rule of thumb, if you've seen one captive, you've seen exactly one captive. What we do is uniquely different than any other employee benefits group captive in the country. So naturally, I will pivot and work towards the value of Pareto. But I will do my very best to keep it, specific to self-funding and to the captive model as we go through the session. But I will give you an introduction to Pareto. We'll talk about carrier profit, fully insured, especially in the mid-market. We define that as 25 to 1,000 enrolled. Those are the employers that are really subject to healthcare inflation more so than any other segment in the U.S. healthcare population. We'll talk about that healthcare inflation, and then we'll get into the mechanics of self-insured. That'll include how do you structure it, how do you set it up, how does stop loss work, and then we'll talk about the pitfalls, right? The traditional market, maybe other captive programs where there's going to be a volatility associated with it, where the juice might not necessarily be worth a squeeze on a year-to-year basis. And then we'll get into why Pareto is having the successes that we are with our contract, with our robust cost containment portfolio, and with our like-minded membership around the country, everybody rowing in the same direction towards better healthcare outcomes for them and their employees. And then like I said, we'll try to leave time at the end for a Q&A. And I do encourage you not only to wait for the Q&A, but during the session, please send in any questions you have into the chat. I know the team's going to be monitoring them. We'll address some of them as we go, but at the end, we will certainly make sure that all questions are asked and answered. So a little bit about Pareto Health. Pareto Health is a captive manager. So we have 4 employee group benefits captives. They are known as the Pareto Captives. They're all their own individual LLCs. They're their own insurance companies, and they are 100% owned by the employers that are participating in the program. So we refer to them as members. If you join a Pareto Captive, you are a member of the like-minded community. You are a self-insured employer with your own individual stop-loss policy, and you are an actual owner of the insurance company. So for everyone on the call that had a dream of owning an insurance company one day, congratulations, this is your opportunity. A quick scorecard, call this our baseball card, if you will. We are at 20. That is the largest employee benefits captive under management in the market by a very significant margin. That accounts for 850,000 covered lives. Think about that as our buying power. That's our pool, our resources. That is the entity that is sourcing stop loss, catastrophic risk protection, cost containment features, employee plan enhancements, prescription drug contracts. You are not just a 50-life group. You are a 50-life group that is part of a collective bargaining power of an 850,000 life entity, which would put us right around Fortune 15 or so. We have a little over 4.4 billion in healthcare under management. So that's the cost of the claims, the stop loss insurance, the administrative expenses, and then the pool of stop loss premium. This is the big item. We're pulling $1.3 billion of stop loss in our program, and that is where we're able to get the reduction in volatility around the things that you can't control when you move into a self-insured environment. And I think the best stat that we could share, since we opened our doors in 2012, we've placed 8,300 stop loss renewals, and we've renewed 96%. So the employers, whether they were self-funded, they were fully insured, level funded, when they led with their feet, they decided to join the Pareto Health, a Pareto Health captive at the advisement of their consultant, like our folks here at InterWest. They tend to not leave, right? The program is working, the math will work. The opportunity that's in front of you is robust, and we're excited to kind of kickstart our journey together today with some high-level education. Here's where we like to start. This has nothing to do with Pareto. This is just the landscape of the industry and where we are today. Since the Affordable Care Act came into place in 2009, this is the list of the major carriers. I'm sure you recognize most of them: UnitedHealthcare, Cigna, Humana, Centene, Anthem. This is a look at their NASDAQ listing, their stock price versus the S&P 500 since the Affordable Care Act went into place. The big part of that event was essentially there was a set medical loss ratio requirement of 80 or 85%, depending on the size of the group, but let's just call it 85%. Ultimately, what the government said was, as a health insurer, 85 cents of every dollar is supposed to go towards paying claims. So now there's a fixed margin on your profitability for your business. In that same period of time in which there has been a fixed margin, their stock price and their value of their company has skyrocketed. How do you increase your profitability on a fixed margin? The only theoretical way to do that is to increase your volume, right? What is volume in healthcare for around fully insured plans? It's premium. This is why you're seeing trend increases move from 5% to now in the low double digits. You're going to see 19.9% increases and being told that that's trend. And in California, you're not going to be given much, if any, information. Well, how much of our premium was used towards paying claims? Well, how much of our claims were towards our pooling point or our large claims or catastrophic claims on plan? This is really limited information. California is the most restrictive from a data perspective for fully insured employers. And really, these mid-sized employers are being left in the dark while their increases in premium are going up at the highest inflation rate in anywhere in the country, right? So healthcare is about 17 to 18% of our GDP. When it's inflating at a rate of 10, 11, 12% per year with no rhyme or reason, I think more and more employers are asking themselves, well, what's the deal? Is there a better way? Is there a way to get access to transparency? Being self-insured is an opportunity for you to do that, right? So I'll touch base a little bit more on this. How are you increasing your renewals and your fully insured premiums year over year at such a high rate? Well, they're doing it in a few different ways, but one, first and foremost, they want the cost of your care to go up. They want healthcare to be more expensive. They want to be able to warrant a larger fully insured increase on their medical plan. They're doing this in a lot of ways, but the one that I'll pick on the most is around your prescription drugs. So United Healthcare Corp owns Optum Rx. Anthem owns Carelon Rx, right? There's the consolidation of the pharmacy benefit managers and the actual healthcare companies in which they're able to pull more levers from that spectrum to drive up your premiums. I'll give you a quick example. Humira, very common high-cost specialty medication. That drug costs a ballpark at around $100,000 per year if you have an employee or dependent that's getting access to that drug. What United Healthcare and these other carriers through their pharmacy benefit managers have done is they're not using their volume and their buying power to negotiate a reduction in price to therefore provide more value on the healthcare plan. They're negotiating a rebate. So they get to spend $100,000 on your plan that goes on your medical expense that gives you a higher medical loss ratio that warrants a bigger increase, while also taking $70,000 of a rebate, putting it in their pocket and reinvesting it back or providing it to their investors as a publicly traded company versus their fiduciary responsibility of the lowest net cost to your plan, right? So that's just one of many examples. They're double dipping on the drugs to drive up your premiums, and that is why you're seeing trend increases at an unsustainable rate. And here's a quick look at United Healthcare. Just going to pick on United Healthcare. They are the biggest. They are the baddest. Right? They're the 5th largest company in the world. All the other carriers kind of follow suit behind United Healthcare, but this is their operating margin between United Healthcare Group and Optum Rx since 2012. As you can see, their operating margin is shifting drastically towards their pharmacy benefit management practice because this is the lever that they pull. This is how they can drive more revenue for their organization and their shareholders. I digress for a little bit. We're just going to talk now through the landscape that is healthcare. Typical cycle, employees underspend on primary care, on wellness. They underspend on what's most important. They overspend on prescription drugs. They overspend on hospital visits or emergency room visits. Employers' costs go up. Employers they're forced to reduce their benefits, increase deductibles, increase copays, coinsurance, water down the plan, or shift costs onto the employees with a bigger deduction, sometimes both. If we look at a group that their all-in cost is $2 million today. So that's the number of enrollment on your census with the rates that you have with your fully insured carrier, your level funded carrier, whatever program it is that you're in, but it's bundled. And your total annualized cost is $2 million at an average increase of just 9% per year, which in today's climate, if your benefits broker has brought you a 9% renewal, that's not the worst case scenario. That's not the worst news that you've ever heard. If we look at that compounded year over year for the next 10 years, that group is going to spend over $30 million on healthcare, right? I think more staggering, if we look at year 1 versus year 10, the cost to fund your healthcare plan for you and your employees and your dependents is going to be more than double what it is today. And this could range, right? A smaller increase, a larger increase. But if we just average out 9%, which is under fully insured trend in the mid-market right now in this country, this is too high of an inflation rate. I don't know if this is sustainable for mid-market employers around the country that are looking to continue to offer benefits and continue to be in business over the next 10 years. What we're asking employers to do, no longer look at this in 12-month increments, look at this in 10-year increments. If we can take $30 million of expected expense with data, control, transparency, flexibility, control over what drugs and the formulary that we're putting in place, I like our chances to be able to skinny down or trim down as much of that $30 million as possible and reinvest back into our healthcare plan, reinvest back into our business. Quick breakdown, a majority of employers, not in California, but a majority of employers around the country are actually self-insured versus fully insured. Rule of thumb, the larger the group, the more predictable the outcomes, the less volatility, the more likely they are to self-fund, right? The larger employers for the longest time have not been subject to Affordable Care Act taxes on their entire spend, carrier profits, expenses, price gouging, spread pricing on pharmacy, because they don't have to, right? Let's just put in a network in place, fund our plan as a self-insured employer, control every aspect of it, and therefore eliminate waste and reduce our trend year over year. And that's how we're able to be more efficient with our healthcare spend and what we're offering to our employees. The other reason is the autonomy that you have when you are self-insured. You want the Aetna network, the Cigna network, United Healthcare, Anthem, Blue Shield, a direct contract with a hospital system, anything you really think of. If you want to structure a PPO with the right network discounts, the right plan, you can do so. You can choose your own formulary. You can choose who you want to administer those claims. The flexibility, I don't want to make it sound like the Wild Wild West, but when you're on a self-funded plan, the flexibility is great. You have an opportunity not to just pick off of a rental agreement, right? And a list or a menu from a carrier. You get to really customize your benefits plan, and you get to do it with real credible data over a 5, 10, 15-year period, to where you're able to structure your plan as efficiently and as robust as possible based on your unique population. I'm going to take a second. I've been talking quite a bit. Grant, anything to add? Any commentary? Do we have any questions that we should maybe answer real quick?
We don't have any questions yet. But yeah, just to add, give Sean a chance to catch his breath and take a sip of water. Well, a couple things there. So with Sean's comment on, United Healthcare and Optum, just personal experience, the lack of control and flexibility is what's leading to these large increases, right? Again, as a personal example with the client, we had a client facing a 37% increase from UHC recently. We identified that it was a specialty drug issue. They had a couple employees taking drugs that totaled, I think, close to 200 grand each, right? So right off the bat, we're looking at 400 grand in drugs that we've got to try and tackle. So we approached UHC and said, hey, can we keep them with you guys and do this with the drugs? And the short answer was no, you cannot do that. So we had to take a little bit of a gamble. We moved them into a captive, moved them into self-funded. And again, the flexibility allowed us to source those medications both internationally and via manufacturer assistance. So right now, those drugs are on pace to cost the plan less than 50 grand this year instead of 400. So again, the flexibility is what we're aiming for with these captive arrangements. And I heard something yesterday that I thought stood out. I had a meeting with an employer group, and they said, hey, I thought captives only started to make sense at 500 lives. So a large part of the reason we do these webinars is around education, and Sean can attest to that, obviously. So I think we're starting to see some of the, old guard of misinformation, if you will. Again, Sean can attest to this. We've got groups in Pareto right now that have 100 employees, 90 employees, and only 60 or 70 on the plan. So the question that we ask folks a lot is, what's more risky than a 51% increase with no claims data? And that's kind of what we're dealing with some of the fully insured carriers nowadays. So just, think on that. Again, don't have any questions in the chat box yet, but we'll continue to look at that. And just wanted to add a little bit of detail there to give Sean a break. So go ahead, buddy.
All right. So the next few slides, we're going to talk about the structure, right? How do you build your self-funded plan? The first thing you're going to do is choose a third-party administrator. This entity is going to do what the fully insured carrier does for you today. They're going to administer the claims. They're going to handle loss control, right? They're going to be able to provide Grant and team at InterWest with information on certain medications that hit plan or certain diagnosis codes that hit plan. And now they're going to be able to help the TPA proactively manage your spend and the suitable care for that employee or dependent in real time versus just in retrospect of what happened and then getting a deferred increase on next year's spend. They're going to provide data analytics. What are we looking at? Why are we looking at it? And how impactful can it be? Is our goal to make the plan more robust when we look at this data? Is it to cut costs in certain areas where we have an opportunity to do so? Or is it both? You're going to have the option as an employer because the data is not only going to be available, but it's going to be controlled and centralized, given to you in a very easily digestible way to where you can continue to evolve your healthcare plan through time. They're going to provide the PPO cards. They're going to provide the member engagement. They're going to do everything that the plan does or is supposed to do on a PPO. The employees themselves are not going to see any different experience. They're going to have their copays, deductibles. They're going to have access to the same robust network that you have today, or another one that's likely more robust. And then they're going to have access to go to Walgreens and CVS and Costco to get their prescription drugs. It's going to look and feel the exact same way. It's just going to be customized and data driven, which is where the opportunity really comes from. The second piece, and this is the actual insurance you will buy when you are self-insured, and this is whether you're in a captive or you're standalone self-funded, you have your own direct stop-loss policy. Think about this as your catastrophic claims reserve. This is the protection against the things we can't control, right? So when you're self-insured, you're going to buy essentially a high corporate deductible is what you're going to buy to help fund your plan. How it's going to work is a portion of your premium. I don't know if everyone can see me, but I'm using air quotes. A portion of your premium is going to go towards your large claim reserve. That's going to go towards your stop loss. And that is what's going to protect you for any individual claimant above that large corporate deductible amount, right? So the example I'm giving today is a $50,000, we call it specific deductible. In fully insured, they'll call it a pulling point that's bundled into your fully insured rates in your plan. The way it works is you as the self-insured employer are going to accrue your premiums, right? So the premiums that you're using today, that you're using for COBRA rates, that you're using for deductions, InterWest is going to help you build the same thing. It's going to look and feel the same exact way. The difference being is when we, instead of sending that number as premium, that's including our deductions from the employees plus our contribution, instead of sending that fixed premium to the carrier, and then the carrier is going to be responsible for paying everything on plan after the employee's out-of-pocket exposure, now you're going to send it to the TPA. The TPA is going to take 20 to 30%, and they're going to pay for your stop loss premium to make sure you're protected against your large claims. They're going to take 5 to 10%. They're going to pay themselves, and they're going to pay the network access fee so that your PPO does what the PPO is supposed to do. The rest is going to be sitting in an ACH claims account. What that claims account is used for is all claims that the plan has to pay underneath that specific deductible. If that specific deductible is breached for a single claimant, whether it's one claim or multiple claims, now you have adequate stop loss protection. That's going to come in and pay the remainder of that claims expense for that individual that's covered by your plan, right? So quick example, I get diagnosed with cancer. I have $500,000 in claims after United Healthcare's discount because that's the PPO we put in place. Your pre-funded account is going to pay the first $50,000 of my claims, and then the stop loss carrier is going to come in and pay the next $450,000 of my claims. We've been able to mitigate the risk exposure above that $50,000 threshold, and that's really because these are the claims that we can't control, right? You could be an employer sponsoring healthcare for the next 10 years. You might not have a single cancer claim. In year 11, you might have 7 cancer claims. You might have a premature baby. You might hire an employee who has a dependent that has hemophilia, and those claims can be between $1 and $3 million per year, right? That's why you're buying stop loss protection. It's the, oh no, what if? Are we protected? Do we have this rainy day cover to make sure that we can continue to push the ball forward and continue to offer quality healthcare benefits? In addition to the big ticket item, right, the specific stop loss, we're also going to give you aggregate protection. What this is if $50,000 is a big number, right? That's a big deductible. If we have too many employees that have large claims that account for over 50 grand, if we have too many employees that maybe typically spend $5,000 on plan, but now they all go decide and spend 10, those numbers, the unexpected amount of your small mid-sized claims, the more predictable claims, when that does happen, you have a big aggregate number that's attached to your stop loss policy that will protect you and say, okay, this is the end of the line. Stop loss is going to come in and pay the remainder of the claims. But the reason we do this is the one good thing about fully insured is it's fixed, right? We know that we're not going to spend anything more than this in the next 12 months. Self-insured, there's opportunity, right? Around a majority of your spend, which is going to be your claims. If we have an unexpectedly bad claims year, too many small, mid-sized claims happen, we know that there is a worst case scenario for that year. We're protected with that umbrella policy, if you will, and that is our aggregate stop loss coverage. Here's a quick example. We're going to compare fully insured versus self-funded. Fully insured, you have taxes, you have carrier profit, you have administrative expenses that are built into the premium, and then you have your claims. When you're self-insured, we're just going to peel these pieces apart, and then we're going to assign a task for each entity that's InterWest and the third-party administrator is rebuilding for you, and everyone's going to be responsible for their role, and their only responsibility is to be a fiduciary of your spend. Right? So you're going to pay your small, mid-sized claims. You're going to pay your administrative expenses. You're going to pay your stop-loss premium, which is an expense to protect you against your large claims. Anything that's unused, anything that we can maneuver or push towards a better RX strategy, a better outcome for that patient who's handling a long-term procedure, whatever it is, anything that was not incurred is now savings for you. That green bucket that we see on the right, this is where the carriers right now on the fully insured side, this is where they're profiting off of your plan. What we're trying to do at self-insurance is give that profit opportunity back to you, put it in your hands, and let you thrive in this multi-year environment. And here's a quick look. I'll keep that $2 million example. So comparatively to a $2 million fully insured annualized spend, if you were to move into self-insurance, the expectation would be roughly stop loss premium. We'd be about 25% of that fully insured fixed premium. This is the insurance you're going to buy. We just reduced it by 75%. Then there's going to be your admin cost. Call that roughly 10%. So you're going to spend $200,000 to hire a third-party administrator, to pay InterWest as your consultants, to coordinate with the pharmacy benefit manager, and to make sure that the employees have ID cards, PPO access, discounts, everything that the plan's supposed to do. The rest is going to be in your actual claims that you as a self-insured employer are going to use deductions and your contributions to pay for. If you look at this pie graph, the vast majority of it is the actual claims. When you're self-insured, the majority of your spend is going to come from the claims that are actually incurred on your population in which you are going to pay for. Everything that we can do, I mentioned this in the previous slide, to mitigate expense, provide better outcomes at a better cost, a better cost for your population, we want to give you more control in that big blue part of this pie graph. This is where your opportunity is. This is why more employers are moving to self-insurance, in addition to the data and the information and the flexibility. And here's a quick example. Let's just assume fully insured versus self-insured. Fully insured, you have a bad year. 54% of plan spend on employer plans around this country are come from 4% of the enrollment, right? So that means if you have 100 people on your plan, 4 enrollees are going to be responsible on average for 54% of the claims that are incurred on plan. So when you get a large increase, an outlier increase from a UHC, from an Anthem, from a Cigna, they're going to come and give you what's called an outlier renewal, right? You breached the polling point, you had too many large claims, they're going to give you limited data on the diagnosis, or if it was driven by drugs, especially medications, if it was an extended hospital stay, you're going to be kind of in the dark. But all you're going to know is you're facing a 30 to 50% increase from one year to the next, which is not sustainable. The worst part about that is, let's say it was 1 or 2 claimants. Those claimants have subsided. They're doing much better now. They're not under that same condition. Or maybe they were on COBRA and COBRA's been exhausted. The rest of your population in the masses are going to go back to consuming healthcare the same way they did before. Is the stop loss carrier in year 3 going to give you a reduction based on your 50% loss ratio, or your reduction in that high cost claim that impacted your plan? No. When you take that big increase, you're starting at a new starting point, and then they're going to try to give you a trend renewal from there. Maybe that one's negotiable because they're so profitable in your account, and InterWest can leverage the market. They can come to you or go back to the carrier and get that 12.9% increase down to 5%. Maybe. The next year, you have a so-so year. Here's your trend increase again. This one's non-negotiable. And this is why, and I don't want to speak for everyone on the call, but this is the historical pattern around fully insured, is we're with a carrier for 2 to 4 years, right? After 4 years, it runs its course. One of the other carriers are going to come in, buy the business at a 20% reduction to our renewal, and we're going to move, disrupt the network, disrupt the access for the employees, disrupt the administrative system that we're accustomed to, and ultimately, we're going to be forced to move and have a new starting point at a 20% reduction, but then we're going to do the same thing over again. When you're self-insured, let's assume that the same outcomes happen year over year with those claims. Your bad years, you're protected by stop loss. There's a governor on your policy that says, okay, you're done with your expense. Following a bad year, if you have that good year, everything that would have been out the door from a fixed premium is now yours to retain, and you get to reinvest that back into next year's plan and the year after. And because it works in this way, where everyone has their buckets and you're able to protect yourself against those catastrophic events, maximize your savings in those good years with control and good consumer-driven healthcare plan. This is what trend very easily can look like for you over the next 10 years. All we did here is we took the $2 million of annualized cost fully insured. We said, hey, okay, nothing went wrong, but nothing went horribly right, or nothing went horribly wrong, nothing went terrifically right. But we're going to reduce some carrier expenses and some Affordable Care Act taxes. We saved $100,000 year one. Nothing to write home about, but $100,000 is still $100,000. Now moving forward, instead of a 9% trend, with data, flexibility, control over our RX formulary, everything that you get when you are self-insured, what if we can reduce the trend from 9% down to 6%? If we can do that, only that same group is going to look at close to $5.5 million in savings over the next 10 years. Grant, anything to add?
Nothing to add. We do have a question. Learn something new from these presentations every time, buddy. Here, I thought I knew what I was talking about, but okay, here we go. Well, we got two questions. Perfect. First one is we're already self-insured with Cigna. Would Pareto be a good fit? I know that's a little bit of a chance for for an infomercial, but I'll let you take that, buddy. And then the second question is, our plan's grandfathered and want to keep this feature. Is that possible? So it's kind of two-part for you.
Yep. So those are really detailed questions. I would encourage a follow-up conversation directly with Grant, the team, and me. If you're willing to set up some time, we can connect very granularly on your group. High level, if you are Cigna ASO, meaning Cigna Administrative Services only, which means it's bundled with Cigna, but you're technically self-insured, the answer is emphatically yes. There is no cost control through that Cigna model, whether you're fully insured or you're bundled on a self-funded arrangement, that you're not able to drive better outcomes. You're not able to carve out the pharmacy from Cigna RX, which is probably Express Scripts. There is savings all over that thing. On top of that, with Pareto's contracts, which I'll get into in a little bit, you're going to have more adequate stop loss protection on a multi-year basis. So where if the claims do run poorly, you're going to find yourself in a much better position. And I can tell you that we have at Pareto in California over the last 4 years, we have brought on roughly 15 groups from Cigna ASO into the captive. We'd be happy to set you up with references to talk to some of those employers, and they could share their experiences, how much they've saved and how much better of a plan they've been able to build with our program and an independent CPA with the consultation of their employee benefits broker. From a grandfathering perspective, I would need a little bit more detail. But ultimately, if you're talking from a self-funded perspective, you have an opportunity to keep a lot of grandfathered pieces in place. There are also an opportunity to review them and see if there's something that you would ultimately want to change for the better. So yes and no, I guess, is my answer. But I would highly encourage whoever those two questions came from to connect with Grant and the team, and let's set up some time to discuss very granularly in a private setting.
Okay, we got a few more coming in, just trying to kind of break it up. We'll keep it fresh here. And this gentleman is actually going to be in Tampa with us, Sean. So me, you, and him will connect about these questions. But all good information there. Let's see. Next question. What would be the minimum number of employees that this plan would work for? I'll answer it from the broker perspective, and then I'll kick it over to Sean. So No minimum per se. In California, we recommend typically like 40 to 50 just due to some of the stop loss regulations for the minimum number of enrolled employees. But outside of California is a little bit more flexible. So I think there's groups down to like 10, 15, 20 enrolled that this might work for. Sean, do you have anything to add to that in terms of minimum number?
Yeah, so it all depends on the third-party administrator, the network, right? The TPAs and the networks sometimes have requirements as well. But if we have a group that is under 100 eligible, we want 50 to be enrolled on the plan. If they're over 100 eligible, we'll go down to 25 enrolled. That's again, great to Grant's point, that's due to some California regulations. But rule of thumb, if you're a small mid-sized employer, you want to take control of your plan, you want to join the Pareto Health Captive, I like our chances to find a way to get it done.
Awesome. Okay, last one, then we'll let you get to it. Let's see here. We are self-insured right now with Anthem, but not bundled. Would Pareto be a good fit? I mean, short answer,
Yeah.
yes. Long answer
So if
is,
they're
what are you looking for?
Yeah, so if they're not bundled, if they're with Anthem ASO, the answer is definitely yes, but it sounds like they're not bundled, so they're probably using an independent TPA, and that TPA is providing them the Anthem network. The answer is yes for an onslaught of reasons. One, again, the stop loss contract. No matter who your stop loss carrier or your captive program is today, Pareto's contract is far superior. I'll get into the nuts and bolts of what that means here in a few slides. Second is our cost management portfolio. It's likely that the third-party administrator you're working with is one of our integrated partners. And with that, you get access to Pareto's cost management menu, and you get to elect and choose any one of these highly vetted, very valuable programs that we pull in as part of our mission. And you can add them to your summary plan description and drive better outcomes. On top of that, depending on what your enrollment is, you could have access to our RX consortium, which will outperform any RX contract in the country. So short answer is yes. The good news is too, let's just assume you're with a TPA like BRMS and you're using the Anthem network. We can ultimately provide you better value on your attachment point with the ICM portfolio and our RX contract without disrupting the employees, the plans, who's the administrator, what the network is. Everything will look and feel very easy. Those takeovers for us are very, very easy. You can consider it kind of a stop loss swap with great upside and great value attached to it. So again, that's probably one that we want to talk off thread about, figure out exactly who your third-party administrator is, what you're doing for your pharmacy benefit manager, and then we'll talk about the value of Pareto's contract, because that's, at the end of the line, what you're buying is Pareto's stop loss policy that no one else can emulate. All right, Grant, I'm going to move ahead. We're going to kind of touch base a little bit on that over the next few slides, but I talked about all the advantages of self-funding. I'm making it sound like it's the easiest decision ever and it's the greatest thing since sliced bread. There are some pitfalls to self-insurance when you are standalone, right? Or when you're in a program, a captive program that doesn't have certain plan provisions built in. They don't have the size and scale, the volume to be able to accommodate those plan provisions. Or if you're directly with a stop loss carrier, or if you're ASO bundled with a BUCA carrier, Blue Shield, United, Cigna, Aetna. When these claims hit your plan, these catastrophic claims, here's an example of what they can potentially cost. What the open market has done, or what the traditional stop loss market has done, is they've really taken a multi-year strategy and they've thrown it directly out the window with the ability to laser your large ongoing catastrophic claimants. The term laser, what it means is they can set an individually specific deductible for a specific risk that's on your enrolled population. So I gave that example of a $50,000 specific deductible earlier. Let's assume that I work for your organization and you're on a direct stop loss contract, or you're with a captive program that has a provisions built in that are more in line with a direct stop loss contract. I have $500,000 in cancer claims. For that first year, we're covered. It's a 12-month policy. We're going to pay the first 50. The stop loss is going to come in and pay the next 450,000. But at renewal, I'm still on plan. My condition has not gotten better. The carrier, looking at the diagnosis notes, the nurse management notes, everything that's available to them, included with your renewal, they're going to say, hey, Sean, looks like this is going to be a large ongoing risk. and we're expecting another $500,000 in claims to be paid for Sean on your policy as the plan sponsor. So what we're going to do is we're going to laser Sean, and we're going to set his specific deductible at $400,000, right? Everyone else who didn't get sick or didn't have a catastrophic event is going to have that same $50,000 specific deductible that we agreed to, except for Sean. We know about this. It's no longer unknown risk. We're going to remove ourselves from it and push that liability back onto you. So now your plan is going to have to pay the first $400,000 in my cancer claims before stop loss even pays $1 in reimbursement. This is too volatile in the mid-market. This works. A laserable contract can work if you're much larger, right? If you're over 1,000 enrolled, you have the size and scale, you have the enrollment, you have the volume to be able to weather a laser like this. When you're in the small mid-market, when you're in Pareto's really niche market, call it 25 to 1,000 with a really hyper focus on 50 to 750, this is not sustainable. This is what's driven employers to stay fully insured or stay bundled. In addition to the laser, right, being able to carve out the risk that we don't want to cover anymore, they can give you an uncapped stop loss increase most cases, right? So 60, 70, 80% increase on your stop loss, which was a lower expense item. Once that expense starts to get too high to protect you against your large claims, you'd have to have too good of a small claims year to be able to continue to save in this environment. We might as well have just stayed fully insured, right? So in the open stop loss market or with other captive programs, you can purchase no new laser provisions. You can purchase caps on increases. They come at a significant cost, and they are all removable. I've never come across a program that has a guaranteed cap, no new laser provision that can't be removed in future renewals. So if you think about a group that maybe has those provisions in place, they have $1 million hemophiliac dependent on plan, they won't laser them and they won't give you an increase larger than their agreed upon cap that first renewal, but included with that renewal proposal, they're going to remove both of those provisions. So next year, not only the hemophiliac, but anyone else who happen to have a catastrophic event is now laserable, and you're subject to an uncapped stop loss increase. So while you can take a 12-month policy and you can purchase riders for a cost to turn it into a 24-month policy, no one in the open market has a guaranteed multi-year contract that protects you with tail. So that's the pitfalls of self-insurance and stop loss. Now we'll get into Pareto and why we're having the successes that we are. Again, I mentioned 96% retention over 8,300 renewals. We've grown at an average of 43% per year since we opened our doors. We expect to write 1,000 new members this year in 2024. That's February 1st, 2024 through January 1st, 2025 effective dates. We have gone from 30 employees in 2020 to now well over 250 employees. This is a thriving environment. It's because we believe wholeheartedly that our two-part mission and our directive as an organization is on the right side of the fight. The first part of our two-part mission is we want to reduce the volatility of catastrophic claims. The way I like to put that is we want to make self-funding realistic for more employers down market. This isn't just for the large 1,000+ employers anymore, the Fortune 500. You too can self-insure with the reduction in volatility around your large claims through the Pareto Captive. Second, after we use that reduction in volatility to give access to self-insurance to more employers, we create this like-minded community of employers around the country. Now we have the size and scale. Let's leverage the market to help you reduce the majority of your spend, which is going to be your actual claims. These are the claims underneath your specific deductible on your stop loss protection. And we do that through our robust cost containment portfolio that we vet, source, vet, and then make accessible for all of our members within the program, depending on which third-party administrator network arrangement that they're working with. So mission number one, Pareto's pool is massive. Right, we are the largest employee benefits captive in the country, and our stop loss performs at, on average, a 40% reduction to leverage trend compared to the largest stop loss carriers in the U.S. market. We're using this model, this high-performing risk pool, to underwrite our stop loss for each individual policy that we bring into our program. Here's a quick example. We're going to underwrite your group just like any other fully insured, level funded, any other direct stop loss program. We're going to look at your network, the access based on the census and the employee zip codes, the plan designs you have in place, we're going to give you essentially a risk score, and we're going to give you an individual stop loss policy, just like you would get if you went to the open market. The difference being is once you join Pareto, think about your individual stop loss premium being thrown in a big, massive bucket with $1.3 billion in it. And then as the year goes on, each employer, when they have an eligible reimbursement on their individual policy, they're going to dip their hand in that big, massive bucket, and they're going to pay their claims. Because we're using and controlling the pool on the stop loss like that, we're able to reduce the volatility. All we're trying to do is say self-insurance is a more efficient way for you to fund your healthcare plan. More flexibility, control, less taxes, carry profit, waste, more control over the pharmacy spend. But it can be volatile because of lasers, because of uncapped stop loss increases. We're trying to make this just a little bit steadier over a multi-year basis to where you're not going to be subject to lasers that hit your plan. You're not going to be subject to uncapped increases that hit your plan. Pareto's contract includes a no new laser provision for the duration of your time with us and a 30% rate cut, right? So if we only had one of these provisions, we could leverage it one way or the other. Because we have both, and because this is the lowest rate cap in the industry around stop loss, this is the least volatile stop loss policy. I look at our growth over the last 12 years, where we used to be a fully insured play, like this is an opportunity for you to get into self-insurance. Last year, 45% of the 745 new groups that we brought into the program were self-insured with stop loss. They were either ASO, Signet, Anthem, or they were independently self-funded with an independent TPA, leasing a network, and provide or accessing their own direct stop loss policy or in another captive program. They've looked at the value of Pareto's cost containment portfolio. They've looked at the value of Pareto's limited volatility stop loss contract, and they said, this is no longer a stepping stone. This is stop loss on steroids. This is an opportunity for us to move our policy into Pareto to where we can be more protected moving forward and continue to offer the best benefits plan possible. So if I had to break it down, Pareto's a great organization. We're doing wonderful things. But if you had to just, the brass tacks of it all, why Pareto? You're buying the best stop loss policy to protect your plan and your healthcare expense that you can't find anywhere else. That is, take captive as a buzzword, throw it out, say, hey, can I get a stop loss policy with a guaranteed 30% rate cap, no new laser, moving forward to give me 24, 36, 48 month protection versus just 12 or 24 months? That is what you're buying with Pareto. Here's a quick example of how we do it. Every group, let's just from left to right, these are 10% of the membership, right? These are 10% of the Pareto captive employer groups. Every year, there's going to be between 6 to 8% of our groups that, from a sheer underwriting perspective, based on their large claims, should get an increase larger than 30% on their stop loss and or should get a laser. We just draw a hard line. For those 6 to 8% of the groups that had those really tough claims year, the captive is going to protect those groups in that year to make sure that they're weathering the storm and that one bad year is not going to spiral out of control into 2 or 3. What do? We take the yellow premium, what we would need from our underwriting model for next year. We sprinkle it in across the other captive members that had better years, right? So think about in your good years with Pareto, you might spend 2% more on your stop loss, which is only 20 to 30% of your total healthcare spend. So less than 1% of your total spend in your good years to guarantee that when you have that bad year, the captive is going to protect you. I hope that makes sense for everyone. Ultimately, the cool thing to think about here is even though we're large enough, we have enough volume to underwrite this appropriately. We know that 6 to 8% of our groups are going to be protected by that cap increase and that no new laser provision. It's not the same 6 to 8% of our employer groups. If you're with us for the next 10 years, you will absolutely 100% be on the left side of this graph, and you will absolutely 100% be on the right side of this graph. What you're buying is that multi-year protection to know we can continue to be self-funded, we can maximize our profitability in our good years, we can use all Pareto's tools and resources, the prescription drug contracts, you name it, to drive down our costs, provide better outcomes at a better price point for our employees. And if and when we have that NICU claim, if and when we have that dependent hemophiliac or that cancer claim, we know that the captive and all of our collective peers are going to protect us in that year so that we can continue to maximize our dollars and push our business forward. I'll stop for a second. Grant, anything to add before I get into capital, and then we'll touch base on our cost containment portfolio?
No more questions in the Q&A. Let me double check. We did get a shout out for you, buddy. Our company joined Pareto in 2023. Best thing we did, and we noticed the savings right away. So just a little kudos, pat on the back for you. I do have a few more questions, but I'll save that to the end. So let's get through the capital, and then we'll go to the Q&A.
Okay. So as I mentioned, Pareto is just the means to an end. Pareto is an opportunity at the most robust stop loss policy, the peer group of like-minded employers, everyone rowing in the right direction. The members, the employer groups that join our program, they own the insurance company, right? So with that, we need to have proper reserves to guarantee we can pay all stop loss claims on every individual policy and continue to offer the 30% rate cap and the no new laser provision. With that, we ask for an investment into the plan. This is your capital contribution. The way it works is you'll contribute it the first 2 years. So your initial proposal will include a capital contribution. Then you're going to be with us for a year. You're going to get your first renewal going into your second year, and you're going to be asked to contribute another capital contribution. After that, the expectation is you'll never have to contribute again. That asset or that amount, that investment will sit as an asset on your balance sheet, and that is really your ownership of the Pareto Captive as an owner and a member of our captive insurance company. How we do it is 10% of your individually underwritten stop loss premium, right? Your risk score, your profit and loss is going to be directly comparative to what your stop loss premium is for your healthcare plan, right? So if you're a 1,000 life group joining the captive and your stop loss is $2 million, your capital contribution that first year is going to be 200 grand. If you're a 50 life group and your stop loss is $200,000, your capital contribution is going to be 20 grand. If we look at that comparatively, 200 grand capital versus 20 grand, that larger company owns 10% more of Pareto than the smaller company. It's all pro rata based on your risk. So the profit and the risk that you're sharing in is directly correlated to your risk on your group based on your size, your demographics, your network choices, etc. Right? So it's fair value, and this is our large claim reserve. This is also our equity stake in the company. What do we do with the funds? It's managed by Goldman Sachs. We're domiciled in the US, so there's obviously a ton of regulation around it. We cannot be overcapitalized. We also cannot be, obviously, undercapitalized. It'll sit as an asset on your balance sheet. We invested in laddered CDs and T-bills. Every individual investment is under $250,000 per investment on behalf of the captive, so it's all 100% FDIC insured. We have to be good stewards of your money, but we also can't let $300+ million just sit there. So we are investing it in proper investments to continue to let that capital asset grow. Your expectation should be contribute 10% of our stop loss year one, 10% the second year, never contributed again, and the average return on investment historically is around 6.8%. So that asset should grow over time. And then if you ever leave the captive, your initial contribution, any interest that you've accrued in those ladder CDs and T-bills, and any unused premium from the stop loss bucket, this is the big one, that is going to be yours to take with you, right? So the biggest profit driver in the capital is going to be from unused stop loss premium in the big bucket that's helping mitigate your healthcare expense, right? We're just the means to an end, give you access to the most efficient stop loss policy, the most robust portfolio for your healthcare spend to be as efficient, as low cost, and as protected as possible. So if we have $100 million surplus, the captive itself just has too good of a year, you own the company, Pareto does not. So we're going to take that profit and then pro rata give it back to you, and that's going to accrue in your capital asset account and continue to drive your asset that's on your balance sheet. I hope that makes sense for everyone. I think the biggest thing to take from here, if a carrier was able to give you a 30% rate cap, no new laser, and guarantee it, you would gladly spend 10% more in stop loss premium. We're not even asking you to do that. We're asking you to invest 10% of your stop loss premium, hold it as an asset in your name. If you leave, you take it with you. It is ultimately what makes this work. It is ultimately what gives you the protection that you need as a mid-market employer to have the best stop loss policy in the country. All right, next, and I will be quick here because I do want to leave time for an open access Q&A. In addition to the stop loss, 2018, our board of directors, which is made up of employers, we're working at their behest, right? We can't profit from the captive from an unused premium. We don't own the captive. We are the captive manager. We are essentially hired to work at the behest of the members within the program. In 2018, the members came to us and said, hey, you did a great job making self-funding realistic, accessible through the captive program, but what about the majority of our spend, which is our claims? Can you help us there? We took that very seriously, and we created our integrated cost management platform, to where we bring in point solutions, we vet them, we source them, and then we make them readily available for all of our captive members to optionally elect if they want to, meaning they can add this to their plan doc in addition to their PPO. You should think of these as cost containment programs or solutions. We call them point solutions, but you can also think of them as employee plan enhancements. So Cancer Care, it's a secondary oncology program. Progeny Health is a secondary pre-neonatal NICU program. FIA Group is ERISA compliance. One Medical is primary care, virtual and brick and mortar. KISS Card is an unbundled surgical and imaging network with direct pay contracts, to where if you have an elective surgery, if you have imaging, MRIs that need to be done, instead of going through the traditional PPO system, you have another resource that you can go to these direct facilities and get these procedures or images done at upwards of 90% savings versus in-network discounts. Healthcare Blue Book, healthcare price transparency. Springbuck is the data analytics program that we provide to all of our captive members for free, so where they and their consultants can start to use it for forecasting, looking at benchmark data. Is our plan doing everything it's supposed to do? Are employees using teledoc or virtual health, urgent care versus emergency room? How many of our employees are going to and seeking out mental health? Do we need to put in an additional program that'll help address mental health for our employees and their dependents? The list goes on and on. The cool part about this is the list as it is today. This will continue to grow and evolve over time, because our job at the behest of our members via the board of directors is to continue to bring the best-in-class cost containment, HR resources, mental health, wellness, type 2 diabetes. All these programs we're thoroughly vetting every year, bringing into the program with a board vote, and then making them accessible for ABC Tire Company in, I don't know, San Jose, California. If they want it, they're a member of the Pareto Health community, they can have it, they can add it to their plan doc, and most oftentimes there's not an additional cost associated with it. Next, I'll touch base a little bit on this, and then I'll kick it back. You don't have to use our RX contract. Everything in our program is completely optional. But if you did, we have a contract that is what we call a full pass-through. What it means is there is no spread pricing. There is no ability for the pharmacy benefit manager to keep your rebates. Those, if they are incurred, are going to pass through directly to you. I mentioned earlier, this is where a majority of the profit from not only fully insured, but bundled ASO programs, this is the lever that they're pulling. This is where they're making their profitability, even on your self-funded plan. When you move into Pareto, if you want access to a quarterly audited with prior authorization, large claim review, specialty drug management, pipeline management, direct and very thorough verbiage within the contracts, and the ability to control your formulary. If you want a PBM like this, you can source it yourself through your consultant. You can source it through maybe the help of a TPA, or you can check the box and you can take one of our 5 thoroughly vetted pharmacy benefit management contracts that will do exactly that for you. We believe at Pareto that you don't have to use our program, but employers deserve a pass-through transparent fiduciary pharmacy benefit management contract. And if they want one and they can't source it themselves, they have access to it because they are part of the larger purchasing power that is the Pareto Captive. Here's a quick look. We took that fully insured at $2 million. Then we looked at self-insured at 1.9 with a 3% reduction. Pareto Group since 2012, after all costs, so stop loss premiums, admin expenses, and all claims paid, trend at 3.5%. So if your spend is $2 million today and you're fully insured, if you move into our program, our expectation would be that you'll have an opportunity to save close to $8.9 million over the next 10 years. The crazy part about this too is we talked about that vicious cycle and the need to water down your plan to combat inflation around fully insured. Most oftentimes, groups that join our program, the deductible, copay, coinsurance, the plan that they've built originally is going to be much superior moving forward because they're going to have great savings opportunities. They're going to have great reserves built up in their good years to where they can reinvest at a lower deductible, better access for the employees, lower copay, lower coinsurance, the likelihood is that you're not only going to save substantial dollars, but you're going to build a better PPO plan than the journey that you were on prior over this multi-year period. And I will kick it over to Grant so that he can attest to that, because I know that if I look at InterWest book of business with Pareto, I don't think that there's an employer group that doesn't have a lower deductible or a better plan or move to a more efficient, cost-effective strategy over the multiple years that we've been together, while also saving substantial dollars in line with this figure.
I think you would be right, sir. I know that was a lot of information. To seeing a couple people drop off, we'll try and get you guys out of here by 11:15. Last slide here is obviously the member meetings that I mentioned earlier. I know a couple of the attendees today will be coming out to either Tampa or Miami with me and my team here in a couple weeks. But member meetings are great. You could talk to current members. You could talk to prospective members. You guys could kind of share best in practice, which TPAs do you like? Why'd you change pharmacy benefit managers, things like that. But I'm going to leave you guys with two things, and then we've got a couple questions to close us out here. TT will be sending out the recording and the slides, hopefully by end of the day, possibly before then. So on the pharmacy side, really quick, the lowest hanging fruit within your current benefits plan, whether fully insured or self-insured, is the pharmacy benefits. We worked with a group down in Fresno a couple years ago that had an issue with their pharmacy benefits. They were spending $350,000 on one medication. We found it at a different pharmacy just a couple miles down the road for $20,000 to fill, which is obviously still a lot of money, but $20,000 to $350,000 is obviously a win for the employee and the employer. So that's number one. And then number two is, obviously, if you're working with a current broker here at InterWest, feel free to reach out to them, or I could get you to the right people. But in today's market, a second set of eyes on your benefits program can't hurt. I mentioned at the beginning of the call, there's a lot of misinformation and disinformation out there. I know those terms are thrown around like Pez candy nowadays on the news, and maybe don't mean much anymore. But again, just to reference a comment earlier around, I thought captives only made sense for 500 lives when, as Sean and I have kind of said, down to 50, 60, 70, 100 lives in some cases. So happy to do a free analysis for you guys. But a couple of questions here just to get you out of here. Let me see here. Let me pull them up. Again, appreciate the engagement. So Sean, let's kind of do rapid fire here just because we only got a few minutes. Do you know what's the smallest group in the Pareto Captive and what's the largest? Do you know that?
Yeah, we have a couple groups under 25, but they're not in California. Largest group is, we have a few groups over 4,000 enrolled.
Awesome. Thank you, sir. Next one, I can handle this one. Will we need to hire an additional HR or payroll person to manage this if we move into a captive? The short answer is no. You'll have a broker team to help you with that. Sean and his team come with 3 or 4 people from account managers and implementation folks, and then the TPA and pharmacy benefit manager will have a minimum of 2 or 3 people also. So you're really getting an additional, 10 people to help you. So don't necessarily need to hire an additional person. No. Let's see. Sean, this is a question for you. Is ICM an all or nothing solution, or can we pick and choose which of these point solutions we like the best?
Yep. And so not only can you pick and choose each solution if you want this one or that one, you also can choose whether or not you even want the program itself. So Pareto Integrated Cost Management, so our ICM platform, is available with 12 TPAs that are in the market. You would elect Pareto ICM. It's an election, and it's $2 per employee per month, and it's directly billed with a business associate agreement, so a BAA with Pareto Health Technologies. That gets you access to the portfolio. And then once you're in the portfolio, you get to pick and choose whichever programs you want. We honestly encourage most groups not to do everything at once, because that's more paperwork, more contracts. It's a lot. It's more of a crawl, walk, run approach. Put in the things that are Springbuck, data analytics. That's an easy one. FIA group, ERISA compliance. Don't pay for that, right? Let the captive pay for that. There's a few that InterWest would walk you towards in year one. And then you go to the members meetings, you look at your data, you look at your claims, and then you're able to determine effectively which program do we want to pull in, and or do we want to source or vet other programs outside of Pareto, right? Maybe we don't want to use Pareto's cancer program. We want to use this one. That's fine too. All we're trying to do is make point solutions like that, vet them, know if they're high quality, and make them available, and then help educate you on them as we progress over 2 to 3 years. The members meeting is the best thing I could possibly advise any of you to attend. Once groups attend, they tend to attend every single year. This year in Tampa, on April 22nd, we have 1,300 people registered. The one in Miami in May, we had 1,200 people already registered. It is a great group, and the number one thing that you're going to talk about is going to be, hey, what programs have you put in place through Pareto or external to Pareto? What was the success? Is there anything that you did that you didn't like, you want to avoid? You're going to learn more from your like-minded peers than you'll ever learn from Grant or me. But short answer, none of it's required. RX, ICM, none of it's required. The only requirement is that you're accruing your stop loss through Pareto and you're an owner of the insurance company with your capital up to date and invested.
Awesome. Okay, two more. Kind of a loaded question, but first thing that comes to mind, which point solution do you think will yield the greatest ROI to the health plan?
So the cool part about that is it's going to be different for every group. Right. For example, if a group has cancer care in there and they have multiple cancer claims, the outcomes are going to be much better. For a group that puts cancer care in and they don't have oncology situations, it's the benefit will just sit there. I would say the low-hanging fruit, Springbuck, that's a data analytics program. These are usually very expensive. They can be $6 to $8 per employee per month. Pareto provides that for free as part of our ICM platform. That is a no-brainer. Get Springbuck, get access to it, be able to look at your data and use that data to make informed decisions. From a price standpoint, one of our RX contracts is virtually guaranteed savings, but also Grant works with a great PBM consultant in California that has other pharmacy benefit managers that do a terrific job as well. Moving into an unbundled pharmacy benefit management contract is the absolute guaranteed immediate savings. That's the lowest hanging fruit opportunity you have. And then I'd say Kiss Card, unbundled imaging and surgery is kind of a no-brainer as well, right? If you have one elective surgery that was going to be billed at $200,000 after a 70% discount was going to be 60 grand, you can probably get that same surgery with a better surgeon with better outcomes, smaller incisions for 10 grand, right? So that's $50,000 in savings immediately if you have just one of those elective surgeries on plan per year. And then Healthjoy, Pareto picks up a stipend on this. And then there's also enhancements and add-ons that you can add to it. But this is access to the coordination of care. The employees have their entire benefits wallet right there in front of them. They can see their deductible, how much they've spent, where they can go, who's in network. It's very, very cool. I'd encourage anyone on the call to reach out to Grant and his team, and we can set up a demo with a Healthjoy representative. They'll pull up their phone right over Zoom, and they'll show you exactly how the plan works. We use that at Pareto. Accessing healthcare is much easier for me than I would assume 99% of Americans out there.
Yep, love that. Someone asked if dental vision coverage is available in the captive. Short, obviously no, but should be self-funding your dental and vision most of the time anyways if you're around that 100 employee mark. And then last question is what has kind of been the transitioning from Cigna level funded to a captive? That's a great question. So Cigna level funded, kind of sells like hotcakes here in California. Again, just people looking to get out of the fully insured market. I myself I think I have 3 or 4 clients that we've transitioned from Cigna level funded to a captive. Sean, I'm sure you've got a few more too, but can you speak on that?
I don't want to pick on Cigna level funded on the call, but those are we want those groups to consider Pareto, and we want to be able to provide you the education and the quote more than probably any other segment. Cigna level funded is technically an ERISA plan. It's technically a self-funded plan. They have an inappropriate individual specific deductible amount causing for expenses on your premium to be far too high. They also, when you're bundled with Cigna level funded, if you have a great claims year, which they're going to pull levers on, they're going to keep a surplus of it, whether it's 50 or 70%. I don't know what contract's in place. You don't actually control the spend, and you have no ability to actually manage outcomes. You can't carve out the pharmacy from Cigna RX, right? You can't carve out certain J codes that are being billed on the medical plan for a medical procedure onto the pharmacy. I would bet my reputation that if you move from single level funded into the captive, that you would see substantial savings and that you would see a much more robust plan offering for your employees.
Yeah, I would second that. There's a couple of folks on the call. I'm happy to connect you guys that were formerly Cigna level funded or now in a captive. So if anyone's interested in that. And then last but not least, and we'll let you guys go. Again, we greatly appreciate, you guys spending your Thursday morning with a bunch of insurance ding dongs like Sean and myself. We love doing this, love the education. But I mentioned this group down in the Central Valley earlier that's on pace to spend $400,000 less than the year before. And that's only due to our pharmacy benefit kind of a tax strategy. And that's only available in a captive with a partner like Pareto, with some of the independent pharmacy benefit strategies that we implement. So we hear a lot that we won't know if we're a good risk for self-funding until we have claims, which sounds good, but the downside of that is we never receive claims in California, right? So in any scenario, we've just kind of convinced ourselves that self-funding is too risky. So the more data we have, the better we can equip you and your employees, your executives, your finance folks, your HR folks. So again, highly recommend and engage with your broker. If you're already working with an InterWest broker, feel free to reach out to Sean and myself or TC and we can get something set up. But Sean, appreciate you, buddy. Appreciate the time. Always a wealth of knowledge. And to everyone that attended and that's still on, we appreciate it. And we'll get the slides and recording out to everyone, hopefully before the end of the day. So again, everyone have a great rest of the week. TC, thanks again for your help, and everyone have a great day.
Yep. Thank you, everyone. Would love to meet with everyone individually as a follow-up with Grant. So thanks a lot for having me. Appreciate everyone's time.
Thanks, everyone.
Thanks, Sean. Thanks, Grant. Thanks, everybody. Y'all have a great rest of your day.